Well, there's the subcostal four-chambered view that we're very used to, as well as the parasternal long axis that we're very used to with the cardiology. With the trauma exam. But looking in the parasternal short and at the apical four-chamber, that's something that we're definitely going to want to focus on in this lecture as well. So, what cardiac ultrasound views? How do we define them? Well, they're defined by the structures that you see when on the screen, not the position of the probe on the skin, because everybody's got a different chest wall shape, and really what you're looking for are certain patterns on the screen more so than exactly where to put the probe on the chest. Because some patients, the parasternal long is going to be the second intercostal space. I've found it all the way down to the fifth, sixth intercostal space, believe it or not. It's very patient dependent. And most patients don't have all the views. Some people have really nice subxiphoid views. They've got a big liver, and I can see their heart really well subcostally, but they're a heavy smoker, and I go look parasternally or apically, and there's no heart because the lung expanded to take up my cardiac view on the chest. And so that's why patients who have COPD, who are intubated, often have very challenging parasternal or apical views. And you watch a cardiac sonographer, do an ultrasound. They always roll the patient. They stick a pillow under the right scapula, roll the patient left lateral decube, brings the PMI to the chest wall. You can always get better views if you roll the patient to their left. That's the big secret here. Not unlike looking for the gallbladder. The liver is the window to see the heart. We use that liver as our window in order to see the heart. So whenever I do a subxiphoid view of the heart, I'm not looking at the left side of the body. I'm looking right underneath the xiphoid process, using the liver as the window, shining the beam towards the patient's chin with the indicator to the patient's right. Okay, and that's what a subxiphoid view looks like. We can see the four chambers there. This is the right ventricle, right atrium, left atrium. Here's the posterior wall of the left ventricle. The apex is over here, and this is all the liver. Now, the trick to seeing that subxiphoid view is start over at the liver edge and follow it up into the subxiphoid margin. And so you look first at the liver, using that as your window, and then once you're in that subxiphoid notch, have the patient take a deep breath and hold it, aim the beam towards the chin, and this is what you see. We can make out here the right ventricle, the left ventricle, the right atrium, the left atrium. Here's the liver, and this whole thing around here is a large pericardial effusion. And that's the main stuff we're looking for. Here's another example of a subxiphoid view with the pericardial effusion. We can make out all four chambers. We're using that liver. We see a lot of liver at first, and then we go into the subxiphoid notch where we see more of the apex. Without this liver, you cannot see the heart in a subxiphoid approach. So someone who's got a very small cirrhotic liver, you can't get these windows. The problem is when you have somebody who's a big drinker and a big smoker, where now they've got a tiny cirrhotic liver, and now they've got these huge COPD lungs, and then you're wondering if they have a heart in there at all. It's hard to find. You really got to roll them left lateral decube, have them take an enormous breath and hold it, which of course they can't do because they're such bad COPD, and this whole thing becomes a very challenging exam. When you have a nice view of the subxiphoid, though, this is the kind of stuff you're looking for. Again, RV, LV, RA, LA, and we can see the mitral valve between the LA and the LV, the tricuspid valves between the RA and the RV, the liver being at the top of the screen. Now, parasternal long, we're going to aim that indicator along the long axis of the heart with the indicator down towards the patient's elbow, and that gives us that long axis. It's at the third or fourth intercostal space, generally speaking. The indicator to the patient's left elbow, sometimes it's towards the patient's left hip in that general vicinity. You're going to see a three-chambered view of the heart, the RV, the LV, and the LA. And this is really the best way to make out what the valves are doing. And we spent a lot of time talking about the parasternal long axis at the end of this lecture, which I'm going to jump to here shortly. We can see there the left atrium, the left ventricle. The blood is basically starting from here, going into that left ventricle, then being pumped out the aortic outflow tract with the right ventricle here seen at the top of the screen. It's a three-chambered view of the heart, and once in a while you can make out the descending aorta seen down here posteriorly. Here's an example. This is not an actual ultrasound. This is a schematic view of the heart moving. LA, LV, aortic outflow tract. We can see the anterior septal leaflet of the mitral valve right there. That's a very important landmark when we talk about contractility. What chamber lies right here? RV, very good. And that's just another view of it here, but I like this particular heart here. This is a little tachycardic. LA, LV, aortic outflow tract, RV, that's the interventricular septum, and this back here is the posterior wall. I don't know, I can't really see that the descending aorta. It's in around here somewhere. I'm not seeing it very well in that view there. So this is just a normal parasternal long axis. This is what it looks like when you've got a pericardial effusion with the parasternal long axis. We can see the fluid actually on both sides of that heart. So the pericardium, I'll trace it for you. It's out here, kind of falls off the screen, and then it's down here. And the fluid runs anterior to that descending aorta. Because if the fluid runs posterior back here to the descending aorta, then you've got a what effusion? Not pericardial, but pleural. Very good. So the fluid runs behind the descending aorta, that's pleural. If it runs anterior to it, it's pericardial. The short axis is just like the long axis, except now we have the indicator aimed to the patient's right. So you start from that left elbow in the parasternal long, and then you rotate it to the patient's right elbow, 90 degrees from where you found the best parasternal long. And basically, you're going to see the right ventricle, you're going to see the atrium seen very easily, and also the left atrium. You can see down to the aortic valve, which is the Mercedes-Benz sign. Sometimes you can make out the pulmonary valve as well. This is a still image here of that Mercedes-Benz sign. This is the aortic valve seen right there. We can make out the left atrium, the right atrium. This is all the RV out here. And as we go a little more distally, then we can make out something called the fish mouth view, or the mitral valve. So this is the parasternal short. We're seeing down towards the apex. Now we're seeing the apex down here, and then we're back up to that mitral valve. If we go even more proximally in the same axis in the parasternal short, all we need to do is fan the probe more proximally, then we get up to the aortic valve, or Mercedes-Benz sign, with the RV seen up here. Again, it's looking like a donut coming to a center point. You see how that donut comes to like an imaginary center point here? That's the parasternal short axis. We can see the mitral valve, and then we can see the aortic valve in that same plane if we just fan it anterior a little bit. This is an example here of what it looks like when you've got a pericardial effusion in the parasternal short axis. Of the 4 views of the heart, this is probably the one I use the least amount to do my work. However, just pointing it out for the sake of being complete. However, the apical forechamber is quite good for comparing chamber sizes. You place the indicator of the probe towards the patient's right hip, with the probe placed just at the apex of the heart, usually right around where the nipple would be, the patient's nipple, just inferior to the patient's nipple there. And it's a coronal view of all 4 chambers. You've got the heart lining up vertically up the screen with the apex at the top of the screen. And this is when you can really see that the RV is about 2/3 the size of the LV. It's good for the overall function. You can see the atria, the valves. Sometimes it's hard to get this window, but this is what you're looking at. The indicators to the patient's right. We've got the septum of the heart right here. LV, the RV looking nicely 2/3 the size of that LV with the atria below it. This is a schematic view of what's going on in the LV and the RV and the atria with its valves seen there in that apical forechamber. And this is what happens when you've got a pericardial, pretty big pericardial effusion. The heart is actually swinging back and forth. That brings up the concept of electrical alternans. Yes, in this patient, you did see electrical alternans. However, what's the most common EKG finding with pericardial tamponade? Low voltage EKG, because of the electricity is just not making through all this fluid. So, but this is what it looks like on the apical forechamber when you've got a big pericardial effusion. This is an example here, just a nice normal apical forechambered view here. We see the LV, the RV with their corresponding atria down here. Just bask in that nice view. Tell me what you think. Are we ready to move on? I think we are. What are we looking for whenever we do a cardiac ultrasound? Well, we're looking for pericardial effusions, whether or not there's tamponade, whether the heart is standing still, any RV dilatation, for that matter RA dilatation, any hypokinesis, obvious tumors, clots that are super obvious, like and also vegetations that are just screaming at you, and maybe a congenital disorder or two. What can we see with pericardial effusions? Well, they're caused by a variety of reasons, but acutely, the unstretched pericardium can only accommodate up to 200 cc's before the pressure in that pericardium takes over the pressure in the right ventricle, and then the patient's blood pressure starts dropping. The longer it takes to build up, though, the more the patient can tolerate. So if it's a long chronic effusion, like somebody who's got renal failure, who develops uremic pericarditis with pericardial effusion, they can have up to 1 liter or 2 in their pericardium before they get tamponade. And what you're looking for is diastolic collapse of the right heart. So as you know, during diastole, when you expect the ventricle to fill, it actually tense downward. It looks like a trampoline, like somebody is standing on the right heart, jumping up and down on it. You have to differentiate this from epicardial fat, which can be sometimes difficult to do. This is an example here of a pericardial effusion. We can see that there are some loculations going on out here in this pericardial effusion. Here's the right ventricle, left ventricle. This is all the liver seen up here. Just an example here. This is probably a chronic effusion. Why do I say that? Well, there's loculations in there, and that makes me wonder how long that thing has been there.